breaking barriers and bridging the gaps between patients and doctors. Welcome to Brainstorming with the Docs and your co-hosts, Dr. Glenn Harrison and Dr. Kolby Condos. Well, hello everybody, and welcome to this week's episode of Brainstorming with Dr. Kolby and Dr. Harrison. So this week, I'm really excited. I'm going to hit Dr. Kolby with 110 questions and talking about functional neurology. So really kind of laying some groundwork for it for future episodes, so that you can always refer back to this one of knowing really what functional neurology is. So with no further ado, I'm going to get Dr. Kolby to start off and introduce himself.
Hey guys, Dr. Kolby Condos. I'm a functional neurologist, chiropractor, functional medicine practitioner extraordinaire in Grand Rapids, Minnesota. And yeah, I mean, I'm excited. I know you guys are probably familiar with me at this point. If you're not, go back and watch the other episodes. You can get some value out of those guys. How's your week so far?
My week was great. So far, it had its ups and downs, but I think it was excellent. There was some challenging cases. There were some easier cases. I had a reoccurring case dealing with chronic fatigue. I thought the fatigue was gone, and then it started to creep back. This lady was dealing with exhaustion for the better part of 6 years, and her world was going downhill. We managed to pull her out of it, but then she had a lapse, and then we actually found out that there were some digestive issues that started to create a snowball. But then another thing that happened when the digestion piece came offline is brain fog started to surface. Her initial problems were brain fog, but with the digestive episode, her brain fog came back. And that's kind of going to tie right into what you deal with. So I have a pretty good understanding of what functional neurology is. I do a little bit of it, not like you, but maybe for our viewers, if you could summarize, what are the differences between traditional neurology? So if someone's going to their medical doctor and going to a neurologist versus what we're calling functional neurology.
Sure. So with traditional medical neurology or a traditional medical neurologist, they're trained to look for what are called ablative lesions or hard lesions. An example of this would be like a stroke or Parkinson's or something where they can physically see on an MRI or a CT scan trauma or compression or whatever of the nervous tissue. So in the example of a stroke, you can look on a CT scan, you go, okay, there's a blood clot right here, and that is going to cause death of that tissue. That is a hard lesion. What a functional neurologist does is they look at your nervous system and they try to identify any areas that are maybe underperforming or under integrating that may be negatively affecting your quality of life. So a good example of a patient that I work with using functional neurology would be, I caught a patient with really, really early onset Parkinson's that hadn't manifested a tremor yet, but, by the appearance of their face and, watching their reactions and stuff like that, and doing a really in-depth comprehensive neurological exam, we were able to catch her condition really, really early before she started showing those classic symptoms of Parkinson's. So as far as the differences, traditional medical neurologists look for hard or ablative pathology, while a functional neurologist looks for underperforming or under-integrating areas of your neurology in hopes that they can address it before it becomes a lasting problem.
That's great. I think that summarizes the way you packeted it there at the end. I think that hopefully helped. A hard lesion versus underperforming brain or an imbalance in the functions of different lobes of the brain, right? Creating problems. Now, you talked about the exam. I know you do some pretty extensive exams way out in Minnesota. What is if someone walked into your office and they just went to go see a neurologist and they did an exam? And I know this is a big question. Just try to simplify it as much as you can. What would be the differences of an exam of someone, say me going into a neurologist, a medical neurologist, versus me coming into your clinic? What would that look like?
Sure. So most of my patients actually who seek me out for my services have been to a traditional medical neurologist. and have been told either, yeah, we can't find any areas of pathology, try this medication. In some cases that works really, really well. In some cases it doesn't work really well. For a traditional medical exam, as far as the medical neurologist, they're going to do pretty much the same exam, maybe a little bit more condensed that I will do, but they're going to look at it a little differently than I will. They're going to look for indicators of a hard lesion, whether that's clonus, which would be, if I bend your hand back and it's like type of deal, or signs of upper motor neuron lesions or peripheral nerve entrapment or pathology. So they're going to look for hard stuff that they can identify using various studies and stuff like that. Whereas I'm going to do an in-depth neurological exam also, but I'm going to maybe interpret the results a little bit more differently. We're going to look at why, okay, so it's not necessarily abnormal, but it's not normal. So why would that be? And then it's also kind of symptom driven. So you start to break down the condition by that. And then you kind of try to determine where you think that the area that's underperforming is. They call it the longitudinal level of the lesion, whether that's, organ or in the brain stem or, in the central nervous system, in the peripheral nervous system, where you think it is, if it's in the basal ganglia, wherever. Those are a lot of big words, but basically you're just trying to localize where in the nervous system the area that is that's not working as well as it should. Okay,
so to summarize, if the medical neurologist would be looking at studies like imaging, like MRIs, looking for tumors and lesions and injuries. Lesion just means injury. That's how I interpret it anyway. They're looking for these big problems on imaging. That's one of their tools. But if they don't find them, no hard lesions, hard injuries, a lot of times then there maybe isn't many solutions. But that's where functional neurology would actually look at where's the dysfunction rather than where's the looking for something on a picture. Is that kind of accurate?
Yeah, exactly. So it's like, if you have a stroke, here's a stroke. This is what it's going to cause. These are assigned the symptoms of the stroke. Whereas if you go in and you have vertigo and they go, well, it's not coming from his inner ear. It's not coming from like a crystal that's moved around in the inner ear. It doesn't look like they had a stroke in the areas of their brain that's associated with balance and coordination. So we don't know. Mm-hmm. That's when you would go in for a functional neurological exam, and they would try to determine, if you have vertigo, is it a central vertigo? Is it a peripheral vertigo? What do we think is causing the vertigo or the feeling of vertigo? So,
and you talked about the testing, the resolution or the therapy is driven by the dysfunction in the test, right? If you can't move your hand from point A to point B, that'll be part of the treatment, is finding and challenging the human to get their hand from point A to B, generally speaking, right?
Sure. Not only can it be diagnostic, but it can also be therapeutic. In certain applications, you can use the problem that the patient's having therapeutically. If you can measure, their fatigue points and you don't push them too hard, then yeah, absolutely, you can use the findings of the exam to kind of improve that.
And then another thing, it's a little bit of a tangent here, but I think it's important for everybody listening. Functional neurology, from what I understand, it works off the basis of neuroplasticity, right? So if you can briefly give an example of what neuroplasticity is.
Sure. So neuroplasticity is just basically your ability to make certain pathways stronger based on the frequency that you're using it. So one example that I give to people is, if you go to the gym and you want to get 22-inch biceps, you have a couple of options to do that. You can go to the gym every day and you can work out for, half hour every day of the week. You can go to the gym one day a week and work out for 5 hours, or you can go to the gym and try to lift 500 pounds one time, and that's all based on growth, right? So the more frequently you stimulate a neuronal pathway, the more likely it is to develop endurance. And your brain is a very efficient place. So it wants you to be able to get information from point A to point B as efficiently as possible. If you're constantly using one neuronal pool or one pathway, it's going to actually make that pathway bigger, stronger, faster, and more efficient. That's basically the premise of neuroplasticity. Another example would be like You know, if you have traffic that's using one road, a two-track road, and then all of a sudden someone finds out about it, and then they're going to pave it. And then after all of them use the paved road, they're going to make it a highway.
Okay. So it's really a learned behavior.
Yeah. So the more frequently you fire certain pathways or movements or whatever you're trying to do, the more efficient it gets.
Okay. So maybe another example would be like remembering your PIN number on your bank card. If you never use it, you lose it. If you're using it all the time, you actually don't even have to think about it, and it happens.
Sure. We hear this all the time with athletes. You know, it's muscle memory. Mm-hmm. Or for instance, a good example of this would be Michael Jordan. Michael Jordan would play basketball games in his mind before he ever stepped foot on the court. So that's just a way that he was actually firing certain pathways in his brain. We won't go super deep into that, but he was actually firing those pathways to make him more strong and more efficient. So when he was in the heat of battle in the game, he was more efficient than his competitors. Okay,
so now we got the exam down. We know what neuroplasticity is. We have a good understanding of what functional neurology is and how it differs. Once I come into your office and I've got a concussion, we'll just say concussion because I know you work with concussions. What would the treatment differences be with a concussion, with a conventional medical model of neurology, like the pharmaceutical model, versus the functional neurology model? What would be the differences?
Sure. So for that, I mean, obviously, one of their primary interventions in traditional neurology is medications. And sometimes that works really, really well, and sometimes it doesn't. The patients that it doesn't work well, then they come in, you do obviously an exam. You're trying to identify the area of the soft lesion, we'll call it, the area that's underperforming, underintegrating, and then you're going to perform targeted neurological exercises to rehab that weakness, right? So I've often heard, I'm paraphrasing a little bit, but there's a really talented functional neurologist in Florida named Dr. Matt Antonucci, and he's always said that a brain injury, people who suffer brain injury don't recover without rehab. They adapt well if they're not having symptoms. So basically what that means is if you're not actively working to make your brain better following a traumatic brain injury and you don't have symptoms, you're just able to recover really, really, really well. And you're able to adapt really, really, really well. So basically we look at what you're doing poorly at, whether that's looking at your eye movements, whether that's looking at your body's awareness of where it's at in relationship to its environment, whatever it may be. We find what we think is underperforming or under integrating, and then we work to integrate and stimulate those areas.
So in the case of a concussion, how, I know I'm asking you to be as simple as possible, but in the case of a concussion, how does it affect the brain, a concussion, and how does training how could training help?
Sure. So with a concussion, obviously it's trauma to the brain. You know, it's the brain bouncing around in the cranial vault, and it's actually like that pivoting motion in the brainstem that causes a bunch of the trauma. And basically the training is, so say you have a patient that has the inability to hold their eyes still on a target, and this can cause a variety of problems, neck pain, dizziness, whatever difficulty concentrating, mood disorders, blah, 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 blah. So then you are actually going to you're going to find an area of stability within, that patient's gaze, and then you try to work your way out from there. So you just use what the patient is doing well to try to springboard you into what they're not doing well, right? So if you're really efficient, if you're trying to train for the marathon, and you've never ran a marathon in your life, well, we're not going to start you out trying to run a marathon. We're going to build you up to that point. You know what I mean? So we're going to start with, jogging 100 yards, then jogging 400 yards, then 1,600 yards. And then soon we're working up to a half marathon. So it's important to really take a measured approach to try to make it as safe and efficient as possible for the patient and to aid their recovery. Okay.
So the mechanism of a concussion is a brain injury where it's not going to perform properly. It's like, I don't know, if an athlete, if we're using that analogy, an athlete sprains their ankle. Well, maybe if they are bedridden for a long, 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 long time, not only their ankle probably won't heal with proper therapies like physical therapy, if we want to use that, but their muscles will get weaker and weaker and weaker. And then they'll lose the ability to actually perform like they did prior to the injury. Would that be a way?
Yeah, I mean, that's a good analogy. I mean, if you're the last thing that you really want to do following a significant, I mean, for anyone that's ever broken their leg, and you get your cast off your leg, you don't have full mobility of your leg. That's just how it is. And especially with brain injuries, you just have to be cautious because you don't want to blow through the patient's endurance points or their fatigue points or exceed their metabolic capacity. So you don't want to ever make the symptoms worse, because that just shows that you can cause some like localized damage, or you can make, those neurons fire at a rate they're not supposed to. But the whole key is that you have to perform targeted neurological rehabilitative exercises in a controlled, safe, monitored manner, because you never want to do too much. Everyone's gone to the gym. They want to get six pack, so I'm going to go to the gym. I'm going to do 8,000 crunches, and then they can't, get up out of bed the next morning. So the last thing, it can be the same thing for the brain. You do too much, you're going to have a headache, or you get fatigue, or, you lose your temper, whatever it may be. That's the reason that you want to be very cautious, and you want to have a measured and specific approach with the application of neurological interventions. Okay.
And then I know years ago when there was concussions, and it's still, maybe that's part of the philosophy, was bed rest, right? And you get a concussion, you just lay and sleep it off. Explain why that's a problem.
So,
building off what we already talked about.
Yeah. So, I mean, the fatigue, there is a certain amount of research that suggests, taking it easy, doing the stimulus free, right? And then there's also research coming out that's showing that athletes who do like very, very low intensity aerobic exercise actually improve more quickly. There's certain dietary things that you can do. There's certain exercises you can do. Without really trying to gloss over it too much, it's just really important that if you have suffered a traumatic brain injury, you're assessed by a qualified professional is basically what I'll leave it at.
Yeah. Okay. And so now we know all these pieces. What would be cases? We talked about traumatic brain injury with functional neurology, but what other kind of cases or diagnoses or disorders would be a good fit for functional neurology?
Sure. So traumatic brain injury, like we covered, Tourette's, any sort of like movement disorder, Parkinson's, progressive supranuclear palsy, depression, anxiety, all these things can be, treated with functional neurology. Because
all these brain disorders are create, or the brain injury or the brain dysfunction create the symptom, and then it's given a label. Is that right?
Yeah, pretty much. If you have like Parkinson's, it's a lesion in your basal ganglia. If you go to a traditional medical neurologist, they're going to use an MRI. And if you have lost, 80% of your basal ganglia, a certain part of your basal ganglia, then they'll give you the diagnosis of Parkinson's. You can do things to slow the progression of the Parkinson's. The patient that I was referring to earlier, we caught it about 3 years ago. She still isn't using any medications. She really hasn't progressed to this point, and that may or may not be typical. She's a really driven, motivated individual, so she is being as proactive as she can about it. But I mean, that's stuff like that is treatable. Or I don't know about treatable. We can't say treatable, but we can say that we can help manage it. How's that?
Yeah. What other cases have you taken on, or have you seen the outcomes of functional neurology?
Sure. So I'll give you an example of a couple that I had today. I had 2 patients with vertigo. Both of them had vertigo. One is a central vertigo, and the other one was a positional vertigo. The positional vertigo patient responded really, really quickly to using like a certain move. I saw traumatic brain injury. I have 2 of them coming in tomorrow. I mean, the Parkinson's, I see a lot of interesting things. I see a lot of autoimmune cases with like MS and stuff like that as well.
Okay. So I guess the next step would be, how could people get in touch with you if they want, if they're suffering with something, they're given a handful of pills and it isn't taking them to the place they want to be in their suffering? How would they reach out to you, and what would it look like?
Sure. So you can always get us on our website. Our website is northlakeschiropractic.com. You can find us on Facebook, North Lakes Chiropractic and Functional Neurology on Facebook. You can Google us. If you're looking for a functional neurologist near you, you can go to the functional neurologist locator, which is www.acnb.org. And then there's a section called the doctor locator. That would be a good option. Or, you can reach out to me and I will try to connect you with someone who's in your area, or if we can hook up and work together, then we will do that too.
Yeah. Do you take on any functional neurology patients remotely?
I don't usually do the functional neurology remotely because there's no substitution for a really thorough neurological exam, like a physical exam.
Yeah.
So it's really, really difficult to treat patients when they're not physically there. That being said, there's a lot of really, really good functional neurologists that are located all around the globe. So
yeah, and there's some really amazing fishing in Minnesota, isn't there?
That is true. It's the land of 10,000 lakes. There's great fishing here.
All right. Well, I think that's a wrap. So you have Dr. Kolby's info. If you want to learn about functional medicine, you can always reach out to me or visit www.drgharrison.com. And I guess that's a wrap, Dr. Kolby. Do you have anything else to add?
No, I appreciate it, man. I always have a ball doing this with you, and I look forward to the one next week.
Yeah, next week we're going to jump into another section where we're going to brainstorm on some other topics and therapies and solutions to empower our viewers so they really can understand the why of these problems and get some really powerful information. So thanks a lot, Dr. Kolby. I look forward to next week where we can have our next session.
Sounds good, man. Take care.
You too.